The bed is empty. The baby blanket still carries the faint scent of milk. A trail of dried blood stains the edge of the mattress, and in the corner of the room, the nurse's eyes, cold, expressionless, stare into the void as if nothing had just happened. Minutes earlier, she had shouted for help. By the time the doctors arrived, the child was already pale, motionless, and no longer breathing. It wasn't the first time. And, more disturbingly, it wouldn't be the last. And today, we're going deep into the mind of one of the coldest killers ever to wear a nurse's uniform, Beverley Allitt, the so-called Angel of Death. But was she born to kill? Or did society create the monster she became? At 3:42 p.m. on March 5, 1991, staff on Ward 4 of Grantham and Kesteven Hospital responded to a cardiac arrest code for an infant, identified in medical records as Liam Taylor. The child had been admitted earlier that day with minor respiratory symptoms. At the time of the arrest, he was in the care of a single nurse, later identified as Beverley Allitt. The infant was pronounced dead within minutes of emergency intervention. The resuscitation team noted the absence of obvious pre-arrest deterioration. Nursing documentation recorded no abnormal vital signs prior to the incident. Subsequent examination showed no visible trauma. The only notable change was the cessation of respiration reported by the assigned nurse, approximately 90 seconds after medical staff had exited the room. 3 days later, a second child on the same ward experienced sudden respiratory failure under similar circumstances. The attending nurse was again Beverley Allitt. Within a 13-day span, 4 children experienced comparable collapses. 2 died. All cases occurred during shifts when Allitt was the assigned caregiver. All recorded medical notes failed to establish a direct causal pathology. At this stage, medical staff attributed the incidents to seasonal illness. Internal concern was noted in supervisor reports, but no formal inquiry was initiated. No complaints were filed. The hospital administration did not report the sequence of events to external authorities. Normal operations continued. On April 22nd, a 15-month-old girl, Claire Peck, experienced 2 rapid onset respiratory arrests within 1 hour. Both events occurred while she was unattended, except for a single nurse. The child died during the second episode. The assigned nurse was again Beverley Allitt. This time, medical staff raised formal concerns regarding the pattern of incidents. Initial behavioral indicators showed no signs of stress or error acknowledgement from Allitt. She maintained a consistent narrative across all cases, reporting sudden unresponsiveness in each child and claiming to have acted promptly. She continued to volunteer for critical patients and displayed a high presence near emergency cases. Supervisory feedback noted her initiative and emotional control during crises. At the time, there was no active mechanism within the hospital to flag multiple incidents connected to a single staff member. No algorithmic patient monitoring protocol was in place to track anomaly clustering. The repeated collapses were treated as isolated medical emergencies. The first institutional anomaly appeared with the case of Paul Crampton, a 5-month-old admitted with a mild chest infection. After 3 unexplained hypoglycemic episodes, each occurring after intervention by Allitt, blood samples were analyzed externally. Results showed insulin levels over 47,000 millunits per liter. Therapeutic range for an infant is typically between 2 and 20. There was no documented medical justification for insulin administration in Crampton's case. The result led to further analysis of other unexplained events on the ward. Patterns of incident timing, medication records, and staff assignment logs were cross-referenced. Of the 13 unexplained collapses recorded between February and April 1991, 11 occurred during shifts where Allitt was on duty. In 9 of those cases, she was the only staff present during the critical event window. This behavioral clustering was not initially detected due to the isolated nature of pediatric cases. limited digital infrastructure, and a default presumption of innocence within healthcare roles. Psychological screening was not part of the hiring or evaluation protocol for state-enrolled nurses at that time. The convergence of unexplained medical deterioration, consistent caregiver assignment, and eventual pharmacological evidence pointed toward an internal agent of harm operating under the appearance of clinical care. This behavior indicates deliberate concealment within a structured environment that lacked fail-safes for malicious medical conduct. At this stage, no clear motive had been established. Allitt had no recorded history of workplace conflict, disciplinary action, or documented psychiatric diagnosis. Her personnel file showed minor absences due to illness, but no performance concerns had been filed. Witness reports characterized her as quiet and compliant. The forensic trajectory of the investigation shifted from systemic failure to individual agency. The hospital reported the cases to Lincolnshire Police. An internal medical review commenced in parallel with a criminal investigation. The lack of visible resistance in the victims, the absence of forced medical administration signs, and the repetition of similar physiological shutdowns in clinically stable children raised concern about intentional pharmacological suppression. The physical evidence was limited due to routine sterilization protocols and the rapid removal of patients following collapse. The use of insulin as a method of assault, in the absence of diagnostic indication, suggested a caregiver with medical access, pharmacological knowledge, and behavioral adaptability. The observed behavior pattern, coupled with silence following incident escalation, may reflect an established cognitive framework in which harm is rationalized as attention-seeking or role-confirming conduct. Further analysis would require psychological profiling and historical behavioral data. The institution's failure to detect early patterns delayed intervention. The containment of the threat was only initiated after the pattern exceeded internal statistical thresholds and external laboratory confirmation created actionable suspicion. The presence of consistent collapse indicators during isolated interactions with a single nurse suggests premeditation. The absence of resistance and the consistency of the scene environments across victims point to behavioral rehearsal. The lack of defensive behavior by the perpetrator during initial inquiry, combined with passive cooperation and stable emotional presentation, may reflect habituation to fabricated crisis response. The conclusion of the behavioral phase was marked by formal escalation to law enforcement. However, at this point in the investigation, no charges had been filed. The link between motive and method remained undefined. The emotional response of staff remained divided, with no consensus on the presence of intent. The emerging pattern of medically induced collapse, focused within a confined hospital ward, under consistent operational variables, indicates the presence of a controlled, recurring behavior designed to simulate unpredictable medical failure. The delay in identification of the source, despite observable anomalies, may reflect conditioned assumptions of benevolence associated with clinical roles. Between February and April 1991, medical records from Ward 4 of Grantham and Kesteven Hospital documented 13 separate episodes of unexplained pediatric collapse. Of these, 4 resulted in fatal outcomes. A subsequent cross-reference of nursing rosters and patient records revealed that Beverley Allitt was the only staff member present during all 13 incidents. In 11 cases, she was the sole caregiver in the room at the time of clinical deterioration. This pattern introduced a measurable correlation between Allitt's duty shifts and the timing of the critical events. Statistical analysis showed a disproportionately high concentration of life-threatening episodes occurring exclusively during her assignments. No such incidents were recorded during comparable shifts by other nursing personnel. The clinical presentations lacked a consistent medical etiology. Symptoms included hypoglycemia, respiratory failure, bradycardia, and sudden loss of consciousness. In most cases, the children had been admitted for non-life-threatening conditions. Pre-arrest signs, such as oxygen desaturation or infection markers, were not reliably present. No viral outbreak or toxic exposure was identified during the period. Medical staff initially attributed the incidents to atypical winter illnesses. However, the rate and nature of the collapses, in combination with their clustering around a single caregiver, undermined assumptions of coincidence. Pediatric consultants requested an internal review after the death of a previously stable child, Claire Peck, whose fatal collapse occurred twice within 1 hour of treatment, both times under Allitt's supervision. Behavioral reports described Allitt as consistently present near critical patients and often the first to respond during emergencies. She demonstrated knowledge of emergency protocols, but routinely inserted herself into high-risk cases regardless of assignment. This pattern reflects a possible compulsion to initiate or witness acute deterioration, followed by demonstrative intervention. The hospital lacked real-time anomaly detection systems and had no threshold for triggering automatic incident reviews based on staff assignment patterns. This systemic absence of oversight allowed the behavior to continue unchecked. Several senior staff later reported vague concerns, but no formal documentation was submitted until external authorities became involved. The psychological environment on the ward evolved toward suspicion. Parental anxiety increased, particularly among those whose children had experienced unexplained clinical deterioration. Some families began requesting nurse reassignments, while others initiated complaints after discharge. However, without definitive evidence of malpractice, no disciplinary action was taken. On April 25, 1991, a blood sample taken during one of Paul Crampton's hypoglycemic episodes returned from the University of Surrey with an insulin reading exceeding 47,000 millunits per liter. This concentration is incompatible with endogenous production and indicates the deliberate administration of pharmaceutical insulin. The original analysis performed at Cardiff had capped at 500 millunits per liter due to instrument limitations. The sample had been mistakenly interpreted as non-critical due to the equipment's upper detection threshold. Upon reanalysis using a calibrated system, the findings confirmed exogenous insulin presence at toxic levels. No prescription, medical indication, or procedural note justified insulin use in Crampton's case. His admission diagnosis was a mild chest infection, and glucose monitoring was not part of the initial care plan. No nurse or physician had documented insulin administration. The child recovered only after being transferred to an external facility. This discovery introduced pharmacological evidence into the inquiry. For the first time, a biochemical anomaly aligned with caregiver presence and medical context. The combination of unexplained hypoglycemia, non-indicated insulin, and repeated collapse events presented a behavior model indicative of intentional harm, masked as clinical emergency. The insulin evidence altered the trajectory of the investigation. Medical staff were re-interviewed, and patient samples from previous incidents were located in storage at the Nottingham City Hospital laboratory. 9 of 13 archived blood samples were recovered and subjected to toxicological review. Several exhibited similar anomalies, including elevated potassium and detectable levels of lignocaine in patients without cardiac history or treatment indication. The existence of tampered biological samples, paired with the behavioral consistency of the caregiver in question, suggested a structured pattern of deliberate pharmacological assault. The choice of agents, insulin, potassium, lignocaine, reflects a level of clinical knowledge regarding cardiac and metabolic physiology. The specificity of drug selection, combined with the absence of forced administration signs, points to covert delivery, likely through existing intravenous access or substitution during routine medication rounds. Allitt's documented presence during those rounds further narrows the opportunity window. These developments prompted the formation of a joint inquiry between the hospital administration and law enforcement. Internal charts mapping incident times, patient beds, and staff assignments were compiled. The resulting visual model displayed a uniform pattern. In each collapse case, Allitt had either administered care directly or been alone with the child within 5 minutes of the event. No comparative model involving other staff members produced similar overlaps. No consistent non-clinical variable, such as time of day, equipment failure, or batch medication, accounted for the clustering. While the statistical correlation and toxicology results established a behavioral pattern consistent with medical interference, the underlying motivational construct remained undefined. The absence of theft, vengeance, or external coercion suggested an internally driven behavioral reinforcement loop, likely psychological in origin. The observed lack of remorse, emotional flattening, and calculated proximity to high-risk patients may indicate a developing behavioral fixation rather than opportunistic misconduct. However, the psychological mechanism sustaining this behavior had not yet been classified within an official diagnostic framework at the time of investigation. The review of additional blood samples from other cases was still underway, with early indicators suggesting further chemical anomalies. The scope of tampering was not yet fully established. The cumulative behavioral and biological evidence provided a foundation for formal suspicion, but not yet a charge. The alignment of toxicological findings with clinical behavior pointed toward deliberate harm in a controlled medical context. However, the full diagnostic profile of the offender's psychological state remained incomplete at this stage. Archived records from educational and occupational institutions associated with Beverley Allitt display a pattern of persistent absenteeism, frequent minor injuries, and medical complaints that did not align with objective findings. Between 1988 and 1990, during her pre-nursing and clinical training period, she logged over 150 days of sickness absence. These instances were primarily attributed to nonspecific symptoms, including abdominal pain, limb injuries, and fainting episodes. Medical verification was often inconclusive or absent. During her training placements, multiple behavioral incidents were recorded anecdotally, including contamination of shared living spaces with biological waste and repeated fire alarm activations without cause. While no formal disciplinary actions were taken, internal memoranda reflected concern about her attention-seeking tendencies and interpersonal volatility. Reports from acquaintances and former partners described coercive behavior, emotional manipulation, and, in one instance, physical assault. In a documented case involving a former fiancé, Allitt allegedly exhibited controlling behavior, followed by unprovoked aggression. No charges were filed, but the individual later provided corroborating statements to law enforcement during the investigation. These behavioral patterns exhibit features associated with factitious disorder imposed on self, commonly referred to as Munchausen syndrome. The escalation from self-directed symptoms to harm inflicted on others introduces a secondary diagnostic classification, currently recognized as factitious disorder, imposed on another, historically termed Munchausen syndrome by proxy. In this framework, the perpetrator induces illness or injury in a dependent individual to assume the role of caregiver, often to gain attention, sympathy, or perceived competence from peers. This condition is not characterized by delusion, but by purposeful fabrication or induction of symptoms, carried out with full awareness of the deception. However, the underlying motivation is internally driven and reinforced by psychological gratification rather than material gain. In Allitt's case, the behavior conformed to multiple diagnostic indicators. The victims were all minors incapable of reporting symptoms or verifying accounts. The medical crises occurred in clinical settings, allowing Allitt to perform interventionist roles in front of professional observers. In several instances, she remained close to the child's family, offering emotional support, which elevated her perceived reliability among staff and relatives. This behavior reflects a layered manipulation strategy. By positioning herself at the intersection of crisis and resolution, Allitt maintained control over both the problem and its apparent solution. This method maximized her visibility as a caregiver, while simultaneously obscuring her role as the instigator. No incident resulted in suspicion until pharmacological evidence became available. Psychological assessments conducted post-arrest indicated an absence of psychotic features or cognitive impairment. She demonstrated full comprehension of the investigation's nature and consequences. Her affect remained flat, and her responses to inquiries about victims or families showed no emotional engagement. This behavioral detachment may reflect either personality pathology or long-term emotional desensitization. The convergence of factitious behaviors, history of interpersonal manipulation, and compulsive proximity to medical crisis suggests a behavioral construct not primarily motivated by malice, but by pathological identity formation centered on caregiver status. The escalation from self-harm to inflicted harm may represent an adaptive behavioral shift when former methods of attention acquisition ceased to yield sufficient reinforcement. Peer reviews of Allitt's work during the early months of her employment noted her eagerness to assist, especially in high-pressure situations. Supervisors occasionally described her as overly involved or present in areas beyond her assignment. These behaviors were interpreted at the time as enthusiasm, not boundary violation. No psychiatric diagnosis had been formally assigned during her clinical training. Psychological screening was not mandated in the recruitment process for state-enrolled nurses within the National Health Service at the time of her employment. As a result, historical behavioral anomalies were not integrated into her employment risk profile. After the forensic discovery of unauthorized insulin administration and its correlation with Allitt's presence, internal inquiries turned to her behavioral record. Supervisors re-examined previous informal observations, and medical records were cross-checked against documented patient outcomes. The overlap between her duty periods and the onset of unexplained medical events reached statistical significance. At this stage, the working theory within the investigative framework reclassified the incidents from the system failure to deliberate harm enacted by a staff member with behavioral risk indicators. Allitt was formally placed under observation, and her access to patients was suspended pending further inquiry. While direct confession or witness corroboration had not yet emerged, the alignment between her historical behavior, clinical patterns, and pharmacological findings established a credible basis for suspicion. The precise origin point of her behavior remained undefined, and the extent of psychological planning or compulsion was still under assessment. The classification of her behavioral trajectory continued to rely on multidisciplinary interpretation across forensic psychology and medical ethics domains. Following the toxicological confirmation of unauthorized insulin administration, Lincolnshire Police initiated a full-scale investigation into the sequence of unexplained pediatric collapses on Ward 4 at Grantham and Kesteven Hospital. A multidisciplinary team was assigned to conduct forensic, medical, and behavioral reviews across all relevant patient cases from February to April 1991. The investigation proceeded by triangulating three primary data points: caregiver assignments, medication access logs, and clinical deterioration timelines. Investigators created incident charts aligning individual episodes with nursing duty rosters and pharmacy release records. A pattern emerged in which critical events occurred exclusively during Beverley Allitt's shifts, often in close proximity to her physical presence. The pattern of timing showed no random distribution. 8 of the 13 incidents took place within a 5-minute interval following Allitt's unsupervised contact with the patient. This temporal precision indicated an organized behavioral structure, not spontaneous action. Simultaneously, police executed a search warrant at Allitt's residence in Corby Glen. In her personal belongings, officers recovered a syringe not accounted for in hospital inventory. In her bedroom wardrobe, they located a ward allocation book, which had been removed from hospital property. This document contained handwritten notes aligning with the duty periods identified in the internal review. Possession of institutional documentation outside regulated boundaries reflected an attempt to retain unauthorized control over staff assignments and access patterns. The recovered syringe was submitted for laboratory analysis. Traces of insulin were detected. While this item alone did not constitute conclusive evidence of misconduct, its unauthorized possession and biochemical content supported the existing behavioral hypothesis. The concealed nature of the object further suggested an intent to avoid scrutiny. Hospital policy dictated that all insulin stocks be stored in locked refrigeration units within designated treatment rooms. Key control protocols required physical handoff between staff members, with signatures logged at shift change. Interviews with ward personnel revealed that one key had been reported missing during the investigation window. Allitt was the last recorded custodian before its disappearance. Her claim that she passed the key to a colleague could not be corroborated. The pattern of key misplacement, insulin unaccounted for, and missing documentation indicated calculated manipulation of clinical safeguards. During formal interviews, Allitt maintained full denial of wrongdoing. Her responses followed consistent patterns of deflection. She attributed medical failures to unexplained physiological causes and suggested systemic stress on the ward. Her tone remained passive, and her affect was flattened throughout the interrogation process. This lack of emotional congruence with the severity of the allegations was noted by behavioral specialists. No confession or admission was secured. Due to the absence of direct witnesses or CCTV coverage, investigators turned to the remaining biological evidence. Archived blood samples were retrieved from off-site hospital storage in Nottingham. These samples, collected for routine diagnostic purposes, had not been destroyed as per standard disposal schedules. 9 of the 13 cases had viable blood material for reanalysis. Multiple samples showed abnormally elevated concentrations of insulin, potassium, or lignocaine. No clinical indications justified the presence of these agents in the affected patients. These findings supported the emerging behavioral model. The substances detected are all capable of inducing rapid physiological deterioration when administered in controlled dosages. Their pharmacodynamics suggest intentional use to simulate natural medical emergencies. The variation in substance selection, while maintaining consistent outcomes, suggests experimental flexibility within fixed behavioral objectives. This approach aligns with behavior driven by reinforcement through medical crisis management, rather than by direct intent to kill. The integration of forensic evidence with psychological profile data led authorities to initiate criminal proceedings. Allitt was arrested on May 21, 1991, under suspicion of attempted murder and unlawful possession of controlled substances. She did not resist arrest and exhibited no significant physiological response upon notification of the charges. Her compliance was noted, but not interpreted as cooperation. The absence of reactive behavior reinforced earlier assessments of effective detachment. At the time of arrest, there was insufficient evidence to proceed with full indictment on all cases. Allitt was released on conditional bail, pending further review. During this interim period, she resided with a family acquaintance in Peterborough. Within weeks, the host family reported incidents of contamination involving food and pet medication. In one documented event, a family member experienced unexplained hypoglycemia following ingestion of a fruit beverage prepared by Allitt. Veterinary treatment was also required for a domestic animal displaying symptoms consistent with toxic exposure. Hospitalization records confirmed the hypoglycemic event. No underlying diabetic condition or metabolic disorder was identified. Behavioral reports from the household described a return to patterns previously observed in the hospital setting. Unexplained illness following unsupervised interaction with the same individual. No alternative suspects were identified within the residence. These secondary incidents demonstrated behavioral recurrence outside the original clinical environment. The relocation of the conduct to a non-professional setting, despite the ongoing investigation, suggested compulsion rather than strategic concealment. The shift in victim profile, from pediatric patients to members of the host family, indicated that environmental structure, not target characteristics, defined behavioral expression. The reappearance of toxicological patterns in a domestic context expanded the behavioral classification from workplace misconduct to generalized pathological compulsion. The conduct no longer required institutional access or medical authority to manifest. This transition holds relevance in the risk assessment of behavioral recurrence and the scope of potential victimization beyond structured care environments. The capacity to resume harmful behavior during investigative supervision indicates a reinforcement loop unmoderated by deterrent factors. This response pattern suggests behavioral persistence, independent of social context, legal consequence, or relational familiarity. The absence of de-escalation under surveillance conditions remains an open point of analysis in the ongoing assessment of underlying motivational mechanisms. The formal criminal proceedings against Beverley Allitt began in February 1993 at Nottingham Crown Court. She was charged with 4 counts of murder, 11 counts of attempted murder, and multiple counts of grievous bodily harm. The court proceedings included extensive forensic evidence, statistical correlation analysis, and behavioral testimony. The trial was marked by Allitt's refusal to provide oral testimony, her consistent denial of all charges, and multiple reported physical ailments resulting in her absence from several hearings. Her presentation throughout the trial remained clinically flat. Her affect did not fluctuate in response to victim testimony, graphic medical evidence, or prosecutorial argument. This behavioral detachment was consistent with prior interview behavior and reinforced the profile of affective disconnection previously observed during custodial interrogation. No spontaneous emotional displays were recorded. Her behavior reflected internal dissociation rather than active suppression. The prosecution presented medical records, toxicology reports, and time-coded staffing schedules demonstrating statistically significant correlations between Allitt's presence and the onset of life-threatening pediatric emergencies. Testimony from medical experts outlined the incompatibility of the victim's symptoms with naturally occurring conditions. In multiple cases, exogenous insulin and other pharmacological agents were identified in biological samples with no clinical indication for administration. The court considered the operational context of the offenses. Allitt had unrestricted access to medications, clinical notes, and unsupervised time with vulnerable patients. Her behavior exploited the procedural trust embedded in the healthcare environment. No security measures at the time were designed to detect intentional acts of harm by licensed medical personnel. This allowed for unmonitored behavioral repetition over an extended period. The jury found Allitt guilty on all counts. She was sentenced to 13 life terms, to be served at Rampton Secure Hospital under indefinite detention. The sentencing remarks classified her as a continuing danger to the public. The ruling acknowledged both the severity of the offenses and the psychological profile suggesting high probability of behavioral recurrence if not contained. Post-trial evaluations confirmed a diagnosis of factitious disorder imposed on another. Clinical reviews identified persistent traits of manipulative behavior, pathological deception, and the absence of empathy. no psychotic features or delusional frameworks were detected. Her mental state was assessed as intact, with her behavior judged to be volitional and calculated. The question of recidivism was addressed through longitudinal risk analysis. Behavioral modeling indicated that, absent institutional intervention, continued offending would have been likely. Her capacity to repeat harmful conduct while under investigation and outside clinical settings demonstrated an entrenched behavioral reinforcement system unmoderated by external constraints. The behavioral compulsion was not environment-dependent, but identity-integrated. The broader implications of the case extended into institutional policy. Health systems initiated revisions to medication access protocols, implemented staff pattern monitoring, and introduced behavioral risk training. However, structural gaps remained in psychological screening procedures and in early detection of low-level factitious behavior. These unresolved procedural vulnerabilities persist in varying degrees across healthcare systems internationally. The psychological impact on victim families and staff involved in the case demonstrated patterns consistent with prolonged traumatic exposure. Interviews conducted after sentencing revealed symptoms of unresolved guilt, vicarious trauma, and distrust toward institutional authority. These effects were amplified by the breach of trust embedded in Allitt's professional role and the vulnerable status of the victims. From a behavioral analysis perspective, Allitt's profile does not conform neatly to conventional classifications of serial offending. Her actions lacked financial gain, ideological motive, or direct interpersonal animosity. Instead, the offenses emerged from internally driven behavioral reinforcement, characterized by attention-seeking through proximity to crisis. The absence of remorse, combined with repeated medical harm, places her within a rare subset of health care-based offenders exhibiting chronic manipulative pathology. The case raises enduring questions regarding the capacity of institutional systems to detect behavior that masquerades as competence. When pathology presents under the guise of care, conventional detection mechanisms often fail. The presence of structural trust, clinical complexity, and procedural opacity enables offenders to operate without early challenge. Allitt's case illustrates how behaviorally motivated harm can exploit systemic blind spots, particularly where authority and vulnerability intersect. What are your thoughts on the behavioral conclusions presented here? Do you agree with this interpretation, or would you classify it differently?